This is the Neurosurgery Podcast.
Super excited to have you at the Neurosurgery Podcast again, this time with returning champion Carl Heilman. JP and I have had him on for many, many important topics. Today, however, we are talking about celebrities and NPH, otherwise known as normal pressure hydrocephalus. Carl, welcome back to the podcast. Why don't you introduce yourself again?
Well, thanks for having me, Mike. It's my pleasure to be here. I'm a skull-based neurosurgeon. I work at Tufts Medical Center. I was the chair here for 20 years. Stepped down last fall and figure I'll spend the rest of my time just being a surgeon in the department and enjoying that. And we'll get into it, but normally my specialty is skull-based tumor surgery, but I got involved with an idea for hydrocephalus, and that's sort of what led to this podcast. So, you know.
Wow. Well, we'll get back to the e-shunt, right? But the reason we love doing this series is because neurosurgery is always in the media, and not just in like the Hollywood media, in the real media. And of course, the one of the most recent items that came to news is Billy Joel, right? Billy Joel with the normal pressure hydrocephalus. Why don't you, maybe some of our listeners don't know much about NPH, maybe give a little background. It's a mysterious disease. There's also a very complicated history from the past, right, from the 1970s of the overdiagnosis. So give our audience a sense of what NPH really is about.
Yeah, Dr. Wing, I was going to say some of our listeners, medical students, college students, or spine surgeons may be less familiar with normal pressure hydrocephalus. So exactly, Dr. Heilman, a little detail on the disease. We do, jokes aside, we do have some young listeners, even as far back as college, thinking about a career in medicine and neurosurgery. So a little overview of the disease would be great.
Yeah, so, take yourself back to the 70s. There was not routine use of CAT scans or MRIs at that time. And basically, what was first described in the 70s was that there are a subset of patients who develop enlarged cerebral ventricles, and they present with three symptoms: a slow shuffling gait. So when they try to walk, they shuffle. They have cognitive or memory issues, and they have urinary incontinence. And if you do a spinal tap to measure the pressure, which was done quite often back then, the pressure was normal. And some physicians at MGH discovered that even though the pressure is normal, if you put a shunt in those patients, some of them improve. And that's what led to this concept that there is hydrocephalus that doesn't have high pressure, but yet if you do something to drain cerebrospinal fluid from the patient's brain, they get better. And initially, most people thought that you had to have some underlying condition that led to it. For example, a ruptured aneurysm. You then developed hydrocephalus due to the blood that came out of the aneurysm, the subarachnoid hemorrhage. And then several months down the road, the aneurysm has been treated, the subarachnoid hemorrhage has gone away, but then you develop this slow shuffling gait, memory troubles, urinary incontinence, you do a spinal tap. The pressure's in the normal range, but if you put a shunt in those people, many of them improve. And so that originally led to the concept that there was this condition with enlarged cerebral ventricles where the pressure wasn't that high, but draining it could lead to some clinical improvement. And now we know that there are lots of patients who have never had meningitis before, or never had a ruptured aneurysm, or never had a head trauma, and they're just getting older, and they develop this shuffling gait. You do a scan. Keep in mind, as everyone gets older, their ventricles get bigger than normal. So the key thing with NPH we're looking for is ventricles, the cavities in the brain, are out of proportion to the age-related atrophy that patients have. So they have a little more cerebral spinal fluid in their ventricles than they do have age-related shrinkage in the brain. And that's what makes clinicians think about NPH in a setting of this triad of symptoms.
Yeah, I recall early in my training, and I guess late medical school, early training, when I first started learning about normal pressure hydrocephalus, and eventually even learning about negative pressure hydrocephalus and some of these more exotic and rarer and more niche conditions that affect our patients. I remember just being fascinated by the physiology and the compliance curves and the mechanics of the brain as a physical tissue, not just a functional tissue, and thinking about the pressure gradients across the ependymoma of the ventricles. And there was a while when I really went down the rabbit hole, and I really got into this stuff. But I wonder if again, for the younger people listening, since those early days when these patients were identified and they were found to have this triad of classical symptoms with enlarged ventricles, over those ensuing decades, I think there's been a spike in potential diagnoses for this condition, like we've seen in incidental meningiomas or incidental aneurysms being found. The more and more scans are done as CT scanners became ubiquitous and more available. And I think a lot of older people who had non-structural or a different etiology of dementia would fall, hit their head, get a scan, have big ventricles. And so maybe talk a bit about the typical screening process that patients go through when they present. Grandma's getting a little older, the ventricles are large on a scan. It's not like surgeons jump straight to doing an invasive procedure, and particularly a permanent indwelling shunt, the traditional treatment. So talk a bit about how we elucidate which patients may actually benefit from an invasive procedure and exclude those who may not.
Yeah. Part of the problem is that, there's no medical management for this. There's no pill you can take or medication. And so if you have what is believed to be normal pressure hydrocephalus, the treatment has been to put in a shunt. Most people do a ventricular to peritoneal shunt. A handful of neurosurgeons do ventricular to atrial shunts. And the problem with the shunt is the complications have been fairly high. If you look at complications rates, some people say 40% of shunts fail within 2 years, or 22% of shunts have a complication within 90 days. And you put that together with the fact that sometimes you're not sure the person really has NPH, and that the improvement rate after putting a shunt in is somewhere around 60 to 75% or something like that. So the neurosurgeons are sitting there, well, I got a 60 to 70% chance the patient's going to get better and a 20% chance of a complication. I'm not in love with doing a shunt. And so neurosurgeons tend to want to get involved or treat only the best patients that they're convinced. And so this is kind of where the spinal tap test came from. Some neurosurgeons, when they're convinced someone has NPH, they'll just put a shunt in. But others refer them to a neurologist or a physical therapist or one of their nurse practitioners to drain some cerebrospinal fluid out by a large volume lumbar puncture or maybe by an inpatient spinal drain. Take that out and then see if the patient gets better. And if they don't get better, then say it's not worth doing a shunt. If they get dramatically better, then maybe it's worth doing a shunt. And so that's evolved into the decision-making process, some sort of tap test to see if there's improvement.
Yeah,
And
that's a really good point, because I'm thinking back to like the 1970s. There were certainly geographically localized areas where like everybody was getting a shunt for NPH, kind of like piriformis syndrome, right? That's you almost never see it now. But even though we see that, I mean, I can tell you in the several dozen cases I've been able to diagnose in a spine clinic, every single one of them came very late. In other words, these were people almost universally who had been like going doctor to doctor to doctor, and nobody could figure this out. And like nobody even came up with the concept. Like when someone came to see me with NPH, it was never like, "Hey, do you think I have NPH?" They're all like, "Hey, listen, they're about to put me in a home because they say I have Alzheimer's, or I've caught Aquinas syndrome, so I'm peeing on myself." Why do you think that is, and what do you think it is about neurosurgery diseases that we see so much of that? And I'm not just saying NPH. Like you think about a lot of the diseases we treat, AV fistulas, cervical myelopathy. A lot of them come super, super late.
yeah, I mean, I guess I would say this for two reasons. One, it's often mistaken for normal aging.
Mm.
So you're only, say, seeing your general practitioner for a yearly physical and your gait slowing down. And unless the family pushes for an evaluation or something, it's just seen as, they're getting older. Someone has to order an MRI to see that the ventricles are out of proportion to the degree of brain atrophy. Keep in mind, the statistics say that if you're in your 70s, 2 out of 1,000 people have NPH. If you're in your 80s, 6 out of 1,000 people have NPH. And if you're in assisted living, most people think 15% of those people in assisted living have NPH. So it gets more common as you get older, and someone has to recognize that, to me, gait is the most significant symptom. Uh, Cognitive problems, it could be NPH, but it could be a myriad of other dementing illnesses. Urinary incontinence could be prostate, could be pelvic floor weakness. That's. But if someone is sort of hunched over and shuffling and lagging behind everyone else, taking small steps, turning on block, of course, you don't know if it could be Parkinson's or Parkinson's-like syndrome, but someone should be thinking about NPH and consider a workup. And part of this thing about the press, with Billy Joel raises awareness. More people are thinking about it. More people are saying, hey, my mom or dad walk like that, have that problem. And so, but I just think it's so gradual. The onset is gradual. It's not like it's all of a sudden there one day and someone says, you changed this week. We need to work this up. It came on gradually, and people tend to just chalk that off to getting older.
Well, first of all, I would like to take a moment and cheers to you, Dr. Wang, for diagnosing NPH in spine clinic, for all my jokes at the beginning of this episode. But I think that, and in case anyone's judging me, this is cold brew coffee. I know the sun is up. But I think that speaks to, we were chatting a bit before we actually started this recording about how residency training now is, some people are taking advantage and gaming the system and cherry picking which surgeries they want to see and participate in when they reach the senior years of residency. And I think that is a genuinely good example of why it's important to see the full gamut of neurosurgical practice, because when people get referred to your clinic because they aren't walking well, that could be, 100 different conditions could affect your gait. And so having some exposure to and a deep understanding of the different causes and the way to properly work up gait issues is really important. One, of course, to take care of our patients and do the right thing for them, but two, to avoid doing the wrong treatments and getting yourself into trouble, especially when you're early in practice. Also, Dr. Heilman, if that statistic, 15% of people in assisted living facilities may have NPH, if that statistic is anywhere near reality, think about the cost savings we could have as a healthcare system if we properly identified and then treat them with a one-time procedural expense. In particular, a very less invasive procedural expense, even than a traditional shunt. And so, with that, I think let's transition and talk about this new technology, the e-shunt. You mentioned how Billy Joel recently was diagnosed with NPH, and that draws attention to this condition and makes people think maybe grandma has it. But fortunately, there's this high profile interest in the media now in this disease at a time when there's a new technology, a new technique that may be able to offer a treatment to these patients that's even less invasive than a shunt, which admittedly, while it involves an implant, isn't a very invasive surgery in and of itself. But now we could take that risk profile, the hospitalization, down to even lower and lower rates. So please, for our listeners, let's talk about the e-shunt.
Sure. For the first 10 years of my career, from 94 to 2005, I did skull-base surgery and pediatrics. So I covered about a third of my job was pediatric neurosurgery, which meant I had to do a lot of shunts. And so I think somewhere around 20 years ago, I was doing a shunt in the middle of the night, and I was just thinking there has to be a better way to do this. The technology hasn't really changed in 50, 60 years. There's new valves, there's antibiotic impregnated catheters, there's anti-siphon devices, but the basic technology is still the same. And at the same time, aneurysms were just being all switched over to endovascular treatment, away from open surgery, away from microsurgery, away from clipping. And I just started thinking there has to be a way that we can essentially put an arachnoid granulation into a patient from the venous side. So I just started looking at scan after scan and just going through slice after slice, saying, where is there a vein by a lot of CSF that we could go up from the vein side and essentially put a one-way valve in to drain CSF there. And so it turns out that, there's a couple of things to think about. One, venous pressure in veins drops the closer you come to the central venous system. Okay, so if you're in the ventricle in the internal cerebral veins or caudate vein, septal vein, the pressures there probably are 25 or 30. They're higher than ventricular pressure. So you wouldn't want to put a shunt in to those veins because they'll bleed. But as you come down through the through the sagittal sinus to the transverse sinus. As soon as you get to the sigmoid or the inferior petrosal sinus, those sinuses are in bony grooves in the skull base. And the dura and the venous channel is kept open by how that anatomically is structured so that intracranial pressure can't squish and collapse the sigmoid sinus, and it can't squish and collapse the inferior petrosal sinus. And that's because the pressure in the CP angle cistern and CSF in front of the midbrain is higher than the pressure in the sigmoid or in the inferior petrosal sinus. And so I just started thinking, one of those sinuses has got to be a good place to go, because we're going from a lower pressure to a higher pressure. So if we put a needle through or poke something, CSF is going to go into the vein side. Blood's not going to go into the brain side in those locations. So, myself and Dr. Adel Malik, we submitted a patent and garnered some interest in some people who are looking to start a medical business. And we ended up forming a company called Ceravas to work on this. And we decided to focus on the inferior petrosal sinus because everyone of all ages have a CP angle, cerebellar pontine angle cistern. But not everyone has CSF next to the sigmoid sinus. Most people's cerebellum is up against the sigmoid sinus. So if you penetrated there, you might hit the cerebellum. So we decided to go to the inferior petrosal sinus and basically started working with a bunch of engineers and build a model to replicate the human anatomy and then fire through prototypes. Then we started working on cadavers. And finally, we got a prototype that worked. It's interesting, there's no animal that has a venous system like humans except for primates. Dogs, cats, sheep, pigs, they have a totally different venous system. Their sagittal sinus and transverse sinuses do not drain down a sigmoid to a jugular bulb to a jugular vein. They drain down into the paravertebral venous plexus around the dura and the spine and go out through little veins at every foramen. So you can't get to the equivalent of an inferior petrosal sinus in an animal. We tried. You could in a monkey, but we tried one primate, weighed 20 kilograms. That's a 40-pound monkey, and their brain is so much smaller than a human, we couldn't get our human-sized catheters in there. So we decided we didn't want to pursue primates, and so we had to do animal testing in phases of each step: penetration, clotting, this and that, rather than one animal model. Anyway, once we got a device that we thought worked, first we said, well, let's see if it even really works. So we decided to test it in post-aneurysmal subarachnoid hemorrhage patients who have a ventriculostomy in their brain, and their ICP is monitored. So if those people fail to wean from a ventricular drain or are going to go for a BP shunt, we could put the E shunt in instead and monitor their ICP with a ventric and prove that CSF is draining and the pressure came down. So we've done 15 of those, and every one, the ICP went down quite quickly. And so we know it's draining CSF. And then we had to decide on what study to do to work with the FDA, and we decided to go with NPH. One, because you have time to decide, you have time to consent patients. There are good tests to test whether their gait improves. And there's a lot of patients that need it. And so we decided to pursue NPH as something to test the E-shunt on, even though it may work in many other kinds of communicating hydrocephalus. And so we've been doing that in Argentina with Pedro Lilick. We've been doing it in many centers in the United States. And we did an FDA pilot study, and we've now treated over 100 patients, and we're doing our FDA pivotal trial in NPH, where patients are randomized to get either the E-shunt or a standard BP shunt. And then we'll follow them out and for 180 days and see if there's a difference in outcome between the two. And
So
we
Carl,
think there's
tell us.
definitely going to be a safety outcome, a safety advantage. So anyway.
Yeah, Carl, tell us a little bit about the physics of the E-shunt. This is a flow-regulated device? This is a pressure-regulated device? Can you control it from outside the body? You just implant it and see what happens? Are there different types of E-shunts, or is it just one standard E-shunt?
Yeah. Well, as of now, there's only one E-shunt. It's designed at physiologic pressures to drain 10 cc's of CSF an hour. And it only needs a 3 to 5 millimeter of mercury gradient to drain 10 cc's an hour. Remember, everyone makes about 20 an hour. But if your intracranial pressure is higher than normal, the E-shunt will drain more. If it's normal physiologic pressures, normal pressures, it'll drain about 10 an hour. It's 3 centimeters long. And the beauty of that is there's no hydrostatic column that can siphon. That's the biggest problem with standard shunts. when you stand up versus when you're lying down, the pressure gradient between the ventricle and the peritoneum is quite different, and the shunt tends to drain way more in the upright position, even with some anti-siphon devices. But with the E-shunt, it's only 3 centimeters long, so there's no hydrostatic column to siphon. And it has a one-way slit valve in the part that is in the jugular vein, so that if you cough or sneeze or Valsalva, blood can't go backwards into the E-shunt. So you can't, if you had a momentary elevation in central venous pressure, blood won't go in and clog up the E-shunt. But it will only drain when there is a positive gradient between CP angle cistern and the jugular vein, which those two things are closely linked in humans. You bend over, you stand up, you lie down, whatever you do, they go up and down together, and the gradient normally stays about the same in that location. So,
It's very interesting. I mean, just hearing you talk about this, I have to talk to your cerebrovascular and skull-based colleagues that you know way too much about shunt physiology now.
yeah, I never thought I would be, studying this, but you start with a project, and you just have to keep working on it.
So, before we leave the Ishan, I just want to ask you about this because this is so much a part of neurosurgery culture, right? Which is the inventor mindset. That there's so many. Maybe we have so many challenges in neurosurgery that there's too much, fertile ground for for our problems. Like I can think about 1,000 problems in spine I'd like to fix, right? Um, Give us just a brief, and I know you could go on forever about this, but just a very brief concept of what it's like to take a project like this from concept to first in man to clinical trial, like just very high level view of what that's like.
Yeah. I mean, first off, many neurosurgeons have ideas and they just never do anything about it because it's just, too much work or too much effort. But if you're at an academic institution, you have to disclose the intellectual property. Then you got to file patents. Patents can be enforced in different countries. You have to decide you want to go in Europe, you want to go in Japan, you want to go in China. Each one has a cost. You have to pay to upkeep these patents. Then you go through the patent process. Then you have to raise money. Most people do friends and family first and get a prototype and then try to raise more money. Uh, you have to keep track of everything you do in device development. The FDA wants to see a dossier of every step and decision you make. Then animal studies. Then you have to get approval from the FDA if you want to stay in the U.S. for a first in human study. That's analyzed. And then, if everything's going well, then you need to hire people to design a clinical trial for an FDA pivotal trial. And I'll just say there's two major pathways at the FDA. There's the 510K pathway, which means there already is a device, what's called a predicate device, like what you're inventing. So you're compared to that. Say Mike Wang invents a new pedicle screw. He would do a 510K pathway because there's already pedicle screws out there. That is much easier, simpler, and faster than doing the pre-market approval, the PMA pathway, which means there is no predicate device, which we had to go that pathway. So it's much more time intensive and expensive and elaborate to get through a PMA pathway than a 510K pathway. So, but all this stuff costs money, and all along the way, you're paying experts, business people, leaders, CEOs, engineers, FDA consultants, statisticians, and so all this stuff just keeps adding up, such you have to keep raising money. That's the problem. I mean, unless you come up with an idea and you can sell it to an established company, but these big companies that sell neurosurgery equipment kind of want devices de-risked first. They want the company to de-risk it, develop it, show it works, and then they'll come in and consider acquiring it because they have sales and marketing, but they don't want to, so uh, it's a long pathway. I really thought this would take us 7 years when we started, but we started in 2014 and it's 11 years. And if everything goes well, it will be probably 13 years before it gets FDA approval. So we're hoping 2027, but it's a long road.
2027, fingers are crossed for you. Well, I wonder then if, before we wrap up this conversation, I could listen to you talk about that process you described for when you first had the idea, thinking like, wow, could we do something for shunts? Just hearing you describe coming up with the proper model for this device, I could have an hour-long conversation with you about that. Those details are fascinating, but it is timely. My favorite author, Robert Heilman, said, when it come time to railroad, you can railroad, but not before. And so even having an idea like this, as you said, was predicated on the vast advances by our endovascular colleagues, and also the increase in diagnosis for a disease state like this, which proved a good model to try this out for the first steps in our patients. But I wonder if, talking as you were about the path now to FDA approval and being able to bring this truly to market, not just in trials, where do you see this new technology going as NPH continues to get diagnosed in greater and greater numbers, but even outside of just NPH, all the different reasons that we have for diverting CSF from inside the head. We mentioned briefly before that the shunts we have available now, they're programmable. You can access them from outside the body if you need to sample CSF. But also, as you mentioned, this is a brand new device with no predicate device, right? So obviously, you've just made the huge step from 0 to 1. But once this gets out there and people can start playing with it and using it in different pathologies, where do you see a technology like this going, not just a few, but 5, 10, 20 years down the road?
Yeah, I mean, first off, there's been an explosion of endovascular transarterial treatments. To me, we're just getting into the transvenous treatments, and there are many things in the works. There are drug delivery. Uh, if you try to do basically a lot of gene therapy, drug delivery by lumbar puncture, a lot of it ends up in the liver without getting to the brain in reliable amounts. Patients generally don't want an Ommaya or a catheter put into their brain. So this, transvenous approach to the CP angiocistern is a potential way to do a lot of drug delivery to either inhibit certain protein synthesis or to change gene function in the brain. That's a big deal. Anyone with high pressure, other than the NPH, pseudotumor cerebri maybe could be treated that way, communicating hydrocephalus. There may be, you think of anything we do, there's probably a way to do it transvenously. Seizure monitors, intracranial pressure monitors. There are veins that you can use that do everything. So I even did a funny experiment with Dr. Malik. I took applesauce and colored it blue, and I filled up the cavernous sinus with it. And he removed all that stuff with a stent retriever from the cavernous sinus. And I said, okay, now you're ready to take out a pituitary tumor transvenously. Anyway, so, it's a roadway everywhere. So to me, it's ripe for ideas and, different things to work on.
Wow. Well, if the 20th century was the century when neurosurgery was born as a specialty, the 21st century, be it spine or be it cranial, is really going to be the century and the generation where we make it less and less and less invasive to treat these pathologies just as effectively with less risk. And the e-shunt is clearly an example of a powerful, powerful tool in our minimally invasive toolkit to treat hydrocephalus and, heck, maybe even tumors. So our hearts go out not just to Billy Joel, but he's such a spotlight figure for all of our patients suffering from normal pressure hydrocephalus and other diseases that may be treated with this technology. Can't wait to see where it goes once it gets out to the market and more institutions can use it for our patients. For now, Dr. Heilman, thank you so much for coming on the podcast again.
Thank you. I might make one more point if you have time.
Please.
Neurosurgeons always question this high volume LP. Because you make 20 cc's an hour, 240, 300 cc's, maybe 400, 500 cc's of CSF a day, and you go in with a high volume LP and you take out 30 cc's. But yet some patients say they're better for 4 days, 5 days, a week. I've had some tell me they're better for a month. And I've heard many neurosurgeons say that it makes no sense. You're taking out 30, 40 cc's, they're making 20 an hour, it's right back in like 2 hours. But to me, I think it really is that the spinal tap hole is open in their dura for days. And so even though you take out a bunch of fluid, it's leaking into the epidural space for days. And so they're better until that pinhole heals. So to me, a tap test is more than just the fluid you take out that day.
Well, for all the neurosurgeons that you've heard say that, imagine how many residents and even chief residents are out there saying that every time we have to go do the test. So we'll clip that out and send it around to all the residencies for the program directors to put up for their trainees. But phenomenal point. Physiology is never the same in the body as it is in the textbook. And so that's a good thing to remember. Dr. Heilman, thank you so much for coming on the show.
All right. Thank you.